I know how this sounds. The claim that prostate cancer can be treated in a single 30-minute outpatient visit with a cure rate above 98% sounds like that kind of thing that gets shared online and turns out to be wrong. I've been saying it to patients for 20 years, and it's still true. I want to show you exactly why it's possible. Once you understand the mechanism, the 30 minutes makes complete sense. I'm Dr. Ajay Bhatnagar. I'm a radiation oncologist, and I've treated over 15,000 men with prostate cancer. And the best way to show you this is through a man named Tom. Tom is 62 years old. He runs a pool company in Arizona. He built it himself, and it supports his family, his employees, their families. When Tom got diagnosed with intermediate risk prostate cancer, his surgeon told him he needed surgery. 3 months off work. Tom looked at his calendar, looked at his books, and said, that would put me out of business. He wasn't being dramatic. 3 months away from a small business kills it. So Tom started asking around, and he found his way to my office. What happened next is what I want to walk you through. For most men with localized prostate cancer, Tom's experience is actually the available option. They just haven't been told about it. Tom's surgeon told him the truth as far as it went. Surgery for prostate cancer is real, and recovery generally takes months. The data on men over 60 who've had radical prostatectomy shows permanent impotence in more than 65% of cases, incontinence in more than 25%. These are published outcomes, not worst case estimates. External beam radiation is the other common offer, and it means daily weekday treatments for 4 to 8 weeks. The radiation travels from outside your body, through your skin, through surrounding tissues to reach your prostate. That path matters. Your bladder, your rectum, and your urethra all absorb some of it on the way through, and the total dose you can safely deliver goes down because you're protecting all of that tissue, not just targeting the tumor. Tom had been told, pick one, and both of them looked like losing. What Tom didn't know is that neither of those timelines is the binding constraint for localized prostate cancer. Most men facing the same situation never hear about the third option. The treatment that changes the timeline entirely is called LDR brachytherapy, and it's been around for decades. Tom qualified for it on his first visit. If nobody told you this procedure existed before right now, subscribe. That's the whole reason this channel exists. Most men don't find out about brachytherapy until they've already made a different decision. Here's exactly what happened the day Tom came in. Under transrectal ultrasound guidance, I placed 45 seeds directly in Tom's prostate and into the tumor itself. The seeds are radioactive pellets, about the size of a grain of rice. They're made of PD-103, which stands for palladium 103, encapsulated in titanium. That's a radioactive isotope that emits radiation at a very tight radius. It kills cancer cells at close range and loses almost all of its energy within a few millimeters. That matters more than it sounds. When radiation comes from outside your body, it has to pass through healthy tissue to reach the prostate. The dose drops as it travels. To get enough of the tumor, you're sending more than enough through everything else. With brachytherapy, the seeds are already there, right inside the tumor. The radiation goes out from the center. The dose is highest where the cancer is and drops off sharply before it reaches your rectum or your bladder. The surrounding tissue gets very little while the tumor gets the full dose. That's what makes the 98+% cure rate possible. The seeds release that radiation slowly over about 60 days, then go inert. They stay in place permanently. After that, doing nothing. But during those 2 months, those seeds treat the cancer continuously from the inside out. No daily clinic trips, no external beam passing through the surrounding tissue. The treatment is already in place on the day of the procedure. Now, here's the other thing I do during that same appointment. At the same time, I place the seeds, I place a rectal spacer called Barrigel. It's a gel that goes between your prostate and your rectum and holds them apart. That physical separation means the rectal tissue gets even less radiation from the seeds. Same procedure, same appointment, 2 layers of protection. You don't come back for a second visit. It's done at once. Tom also had the option I offer that almost no one else in the country does. Most brachytherapy is done under general anesthesia in a surgical center or a hospital. The patients can't drive themselves. Someone has to bring them and take them home. Tom had his procedure done under local anesthesia only, right in my office. No surgical center, no IV sedation, no long recovery time. He was awake the whole time and he drove himself home. That's not a minor convenience. For a man who needed to keep running his business, it meant the procedure fit around his life instead of requiring him to stop it. I'm going to be straight with you because this only works if it's honest. Not every man with prostate cancer qualifies for brachytherapy. The procedure requires a prostate gland under 60 grams. Most men have a prostate between 30 and 40. So most men qualify on that measure. But if your prostate is over 60 grams, there's a path forward. Several paths, actually. 3 to 6 months of hormone therapy called ADT shrinks your prostate before the procedure. Once it's under 60 grams, we do the implant. It's a detour of a few months, not a dead end. The procedure is still on the table. The cancer also has to be contained inside your prostate. For higher risk cases where cancer has spread beyond the prostate wall, we use a combination approach that can still include brachytherapy as part of the treatment. But the 1-day outpatient version is for the localized cancer. And there are short-term side effects to name plainly. For 1 to 3 months after the procedure, most men experience urinary frequency and some urgency. Some burning too for the first month or two. It's annoying, but doesn't keep you from working, and most men don't need a catheter. The side effects resolve on their own. Long term, in experienced hands with modern technique, the outcomes look like this. 76% of men keep their sexual function. The rectal spacer goes in at the same time as the seeds to protect the rectum, and the peripheral loading technique of the seeds protects your urinary function too. That means placing the seeds away from the urethra, around the periphery of the prostate, rather than right against the urethra. The 98% plus cure rate holds for low and intermediate risk cancer. The one precaution after the procedure: no children or pregnant women sitting on your lap for the first month. That's it. You can be sexually active immediately. Tom came in thinking he had 2 options. He had 3. Most men in his position never hear about the third one. No one told them to ask. The question that changes this is 4 words. Does brachytherapy apply here? If your doctor doesn't perform it, ask for a referral to someone who does. A surgeon's office offers surgery. A clinic that does only external beam offers external beam. The option on the table almost always reflects what's available at that specific practice. Getting a specific opinion is just doing your homework. And if your prostate is too large right now, ask specifically about hormone therapy to shrink it first. Name the path. Ask when you'd be reevaluated. The conversation is different once you know the specific detour has a specific endpoint. Tom came in thinking he had 2 bad options. He left with a procedure date. 45 minutes later, his cancer was treated. The constraint he believed in, 3 months off work, never existed for his case. If you've wondered whether brachytherapy is right for your situation versus active surveillance, watch this next. It's called Active Surveillance versus Brachytherapy: My Honest Verdict After 15,000 Patients.